Hello, everyone. This is Floyd. Um, we're going to be talking about refusal heuristics, but kind of what prompted this was yesterday on the news, I heard a reporter reference the current Republican Party as being Republican light. So, what does light mean? Lite? Well, if you're a fan of drinking alcoholic beverages, think about Miller Lite, Bud Light, etc. Hopefully, you get the point. It's not the full version. In some adventure sports, if you take the easy routes, they refer to that by calling it the name of the river or the route followed by light. You took the easy or cheat lines, and some don't really consider that a full completion or successful completion of the run. So, for some strange reason, I thought about patient care refusals, and then in my head, I coined the term refusal light. It probably already exists, but I swear that I thought about it. So, what is a refusal light? Well, an example of this would be if you obtained a refusal without completing a full physical assessment, without determining capacity to refuse. Maybe you only asked some orientation questions, which is not actually determining capacity. And maybe you failed to accurately explain the risks of refusing transport. This is a refusal light. And if you do this, then you took the cheat route to obtaining a refusal, and your only goal was to finish as fast as possible and to say, yay, I got the signatures. I got the refusal signature. What more could you ask for? Um, Unfortunately, most refusals, when we realize the patient's going to refuse, it's simply a means to an end. So we get the signatures so that we can get back in service. Makes sense, right? How does this apply to heuristics? Well, so the Wikipedia definition of heuristics is any approach to problem solving or self discovery that employs a practical method that is not guaranteed to be optimal, perfect, or rational, but is nevertheless sufficient for reaching an immediate short term goal or approximation. Unfortunately, we as human beings are not rational decision makers. We make decisions using mental shortcuts that are just fraught, full of cognitive biases. Sometimes, if not every time, it works out and it gets us the desired result with a seemingly favorable outcome until it doesn't. Maybe the majority of your refusals end well and the patient doesn't need to go to the hospital. But what until they do? Do you know if the refusal that you obtained your last shift didn't call back the next day because you missed something? The thing about heuristic decision making is that the answer seems to be correct all at the time when you're making that decision, despite the fact that you're wrong, but you just don't think or you don't know that you're wrong. So here's a quick puzzle to demonstrate how using mental shortcuts can lead to the incorrect result. A bat and a ball cost $1.10. The bat cost $1 more than the ball. How much does the ball cost? I'll read that again. A bat and a ball cost $1.10. The bat cost $1 more than the ball. How much does the ball cost? Most people would say, well, if the bat and the ball is $1.10 and the bat costs $1 more, well, then the ball is 10 cents and the bat is $1. Unfortunately, this is not correct, and I think that it is every time I read that question, despite knowing the answer. So if the bat is $1 more than the ball, and $1 more than 10 cents is $1.10, so the total then would be $1.20. So in this example, the bat cost $1.05 and the ball cost Heuristics is very common or it's a major factor in avalanche fatalities because heuristic traps are considered to be a major factor in avalanche fatalities, and there's a lot of literature, a lot of research on this subject. And they think that it is mainly due to inaccurate assessments or perceptions of the hazards. And a lot of people that are involved in these avalanche fatalities are very experienced. They're people that someone considered experts. They're doing this extreme adventure sport, and it's very dangerous. But so some of the heuristic traps that they generally outline when talking about avalanche heuristics are one is familiarity. So it's a familiar run. We've been there before, time and time again. Even if the conditions are different today, we know this place. The next one is social proof. So-and-so just did it. Why can't I? It worked out for them, and they haven't had any issues. The third one is commitment. We're already here. Why not? We're already here. We put in all this time and effort. Why not? The fourth one is scarcity. So it's not something that comes around very often, and we want to grab the opportunity while it's here. And another one, the fifth one, is expert halo. Expert halo. Well, I am with an expert, someone who seems to be an expert, and they must know what they're doing, and they wouldn't put me in a tough situation. Or I am the expert, so I know what's best, and I feel that this is safe for me. So maybe you can apply some of this to refusals, or maybe you can apply it to just medicine in general. Some of these, I think, are directly extrapolatable to what we do as EMS or, EMS providers or clinicians. Some of it might not be. But we all have preconceived notions of how patients should present or behave. All you have to do is Google pain management bias, and you will find tons of literature, tons of articles on how we don't adequately treat patients in pain because of either our own biases or our own prejudices. So that is a major issue, and there's tons of literature on that. But whatever you personally would consider an emergency, so your opinion of an emergency that would necessitate an ambulance transport, is completely irrelevant to that patient's decision and what's going on with them. So if you insert your own bias and say, well, this is not a situation that if I were in, I would call an ambulance, then you are just bringing your bias to the front, and it's going to overshadow your decision making. We all get frustrated with patients that we don't think need to go to the hospital, but it is not our decision to make. It's not our decision to make. Do we sometimes unknowingly influence a patient's decision on whether they should or should not go to the hospital? Yeah, all the time. But should we? No. So you see, if you think it's a call that doesn't warrant your full attention, you're more likely to send nonverbal gestures in your posture, demeanor, tone of voice. You're just going to appear as if you should not be there. So consider for a second a call that's dispatched as a lift assist. When you hear that call go off, what are your initial thoughts? Probably that, why are we going? So I used to think that calls dispatched as lift assist only probably weren't going to be going to the hospital. Why don't we just send the fire department? I should remain available for a true emergency. Interestingly enough, there was a study published, it's been a few years ago now, by Legatt, Leggatt et al. titled Morbidity and Mortality Associated with Pre-Hospital Lift Assist Calls. So lift assist calls were associated with short-term morbidity and mortality. So what they did was they looked at a certain percentage of call volumes in an EMS system. Out of all of those, a certain percentage, 804 were lift assist calls. So we're actually looking at 804 calls. Only 414 of them were for like individual patients. So there were 414 individual patients. So that's kind of strange. There were 804 calls for lift assist, but only 414 patients. Why might that be? Well, 72% of those were just for only one lift assist call, and this was within a 2-week period that they looked at these. 28% of them, which is 116, had more than one lift assist call. 21% or 169 had to go to the ER. 11.6% or 93 got admitted to the hospital, and 9 died. That is 1.1%. 9 of them died within 14 days of a lift assist call. So for some reason, we think that lift assist calls don't deserve an assessment as thorough as any other call, when the truth is that your guard is probably down on these calls, meaning that you're more likely to miss something important. And hopefully you don't think that your patient care report should be as thorough and accurate as on any other call. So these calls are the ones that I personally think, subjectively, are most likely to come back around and bite you if you don't document them thoroughly. So when I read this study, I think, are these patients actually refusing? Are they demonstrating the capacity to refuse? Or are they the ones that are looking to us to try to decide if they should go to the hospital or not? And honestly, a lot of times that's the case, right? Even if we tell the patient, hey, it's really your decision. We can't make it for you. We can just provide you with this information, so on and so forth. The risk of not going to the hospital, even though we are bound to advise the patient of the risk and the benefit of going or not going to the hospital, that can influence their decision. So maybe we think that lift assist calls are not associated with bad outcomes. So therefore, maybe we actually don't provide a very comprehensive and detailed risk or list of the risk of refusals or the warning signs of not going to the hospital. So if we were wrong about lift assist, what else could we be missing? What we think is wrong with the patient, or what could be wrong with the patient, is just the very tip of the iceberg. Sometimes we just don't know what we don't know. Now, there are some heuristic traps or biases that I think are very pertinent and relevant to EMS, to medicine, and to refusals. And I think the two that are most relevant are confirmation bias and overconfidence. So what is confirmation bias? You may have seen arguments on social media where they say, well, you just confirmed your own bias. Well, confirmation bias is the tendency to seek out, notice, and remember information that supports our pre-existing instinct or point of view, but avoiding or ignoring information that contradicts it, right? Maybe you ignore it, maybe you hear it, but you put it in on the back burner because it does not support your point of view. What would an example of a confirmation bias be? I think something that comes to my mind is, let's say you're called for a patient that is intoxicated. You don't obtain a blood glucose or a temperature because the law enforcement officer said that the patient's blood alcohol concentration was elevated. Their BAC was elevated. Therefore, that has to be the cause of their symptoms. The second heuristic trap or bias that I think is probably most prevalent in EMS is overconfidence. You overstate how much you know and how reliably you know it. It is one of those situations where what you know is just the tip of the iceberg and you don't know what you don't know. An example of this would be if you attribute a patient's symptoms to something that is benign but more familiar to you. An example of this would be if you respond to a young athlete at a sporting event that had a syncopal episode, and you're most familiar with vasovagal syncope. So that is what you were taught in paramedic school or EMT school as being the most common cause of syncope. So you say, well, it's got to be this. It is most likely this. Or they were running and they stopped too fast, or they stood up too fast, etc., etc. The list could go on and on. But what you didn't know is that the reason that this young person had a syncopal episode was because they had Brugada syndrome, which is a channelopathy which can cause life-threatening arrhythmias and cardiac arrest. And then days later, at another sporting event, the athlete collapses again and is in cardiac arrest. So overconfidence and confirmation bias can be a significant heuristic trap when obtaining refusals. And it can be a significant heuristic trap in treating patients. When I was perusing my feed on Facebook the other day, I ran across this article titled, "Don't Assume You Know the Weapon When You See a Bullet Wound. Doc Tells Paramedic Trial." And, the caption is, "Two ex-paramedics are charged in connection with the death of Yosef Al," I think it's pronounced Hasnawi, Hasnawi. So what are the juicy details of this case? Well, based on this report, the paramedics on scene thought that this teenager was shot with a BB or a pellet gun, and they stayed on scene for 23 minutes when in fact the patient was shot with a .22 caliber handgun, and he died an hour later. So this physician that was testifying against the paramedics in this case said that, the reason we don't do that, i.e. make assumptions, is because of the unreliability of that kind of information. And then he went on to say a few more things, but he said you can have very significant injuries that are inapparent when you just do an external exam. And I looked into this a little bit further, and it appears that the paramedics in this, quote, landmark trial thought that the primary problem for the gunshot victim was a psychiatric emergency. So this is probably appealing to their overconfidence bias. And I think that some of the most dangerous phrases that you can say when assessing a patient or obtaining a refusal are, "it's just anxiety," or "it's just a lift assist." There's another example of, and you may have seen this, but you can look it up on YouTube, and the title is "Man Suffering Psychotic Episode Left Alone Near Highway by First Responders." And I will give you the background to this in the video. You can see the patient seemingly wandering around on the highway or the interstate, and I guess law enforcement got called and EMS got called. When they get the patient into the back of the ambulance, I think that there are 3 or 4 EMTs or paramedics in the back of the ambulance questioning this patient. You never really see them do a full hands-on assessment. They just sit there berating the patient, and he's not verbal. He's not saying anything. Occasionally he would shake his head up and down, side to side, But it was clear that he didn't have the mental capacity at that time to refuse transport, but he wasn't responding to their question. So clearly they did not determine that the patient demonstrated the capacity to refuse. And at some point it seems that they tried to pawn it off on law enforcement. And I hear a lot of people say, well, it's not our job to transport psychiatric patients. And I get a little frustrated by this at times. And yeah, I mean, it absolutely is our job if a patient is agitated and combative, which wasn't the case here. But who else is going to take care of that patient? But they kept asking the patient's name. They said, just tell us your name. Tell us your name so we can leave and go back to the station. On what planet does a patient saying their name demonstrate that they have the capacity to refuse? And why on earth do you need their name? They spent, I don't know, somewhere around 10 minutes simply asking for the patient's name. Why is that relevant? Why can't they just take him to the hospital? They probably would have gotten back in service faster if they would have just said, okay, we'll take you to the hospital. Let them try to find your family. Maybe they know you. Maybe they can figure out what's going on. But the thing that frustrated me, not more, but equally, was that it looks like they shoved an ammonia inhalant up his nose. And this was just negligence, and it frustrates me every time I see it. And I hate having to show it to other people because it makes me so angry. So, okay, now we know what the heuristic traps are. How do we avoid them? Well, I made a list of 3 things that you can do that I think will help you check yourself for any biases or heuristic traps on medical calls. One is check your ego. Check your ego. Stop thinking that you know more than you do. Ask yourself, what might I be missing? Is there anything I could be missing? And why don't you perform a refusal cross-check? So check your ego, perform a refusal cross-check. We do this for medications to try to prevent medication administration errors. So we perform medication administration cross-checks. Why not do this with your partner? Better yet, if it's a high-risk refusal or a complicated refusal and you're not sure if the patient has the capacity to refuse or not, then call online medical control. That is a very available and reasonable option, at least for me and my department. Consider alternatives. So ask yourself, what else might this be? What else might this be? So I think that the best way to avoid heuristic traps, in addition to using those three mental cues that I recommended previously, is to be objective about it. Be objective about your assessment of capacity. Now, it is important to mention that we often use the terms capacity and competency interchangeably when they're not really interchangeable. Competency, quote, is a global assessment and legal determination made by a judge in court. Capacity, however, is a functional assessment and a clinical determination about a specific decision that can be made by any clinician familiar with a patient's case. So how do you assess a patient for capacity? How do you assess capacity? Well, the patient needs to demonstrate 4 things to demonstrate or to show that they have the mental capacity to make their own decisions. And we should enter assuming that they have this capacity. But they need to demonstrate understanding. So you present the information and they know that information. So if a patient has X, Y, or Z illness or disease, they know that they have it. Take COPD exacerbation, for example. They know they have it. They know the treatment for it, and they know the benefits and risk of the treatment for that disease. Secondly, they can express a choice. So the patient can communicate their choice when you present multiple options. They choose from those options and they communicate their preferred choice. Now, some patients may go back and forth. They might change their choice. If they do that, it could indicate that they lack capacity because they're not expressing a choice. Appreciation is the third measure of capacity or demonstration of capacity. Appreciation is being able to apply the facts that you present, apply it to their own life, and understand its relevance. If they don't acknowledge their illness, if they fail to acknowledge their illness or certain facts about their illness because they have some delusions, then they may lack capacity. Fourthly, the fourth thing that they need to demonstrate is reasoning. So they can compare options and they infer the consequences of the choice. And to get them to demonstrate this, you simply ask, how is not being transported to the hospital better than being transported? This will elicit the patient's values, which are not always in line with your values. It requires the patient to compare the consequences of what they want to do compared to what they do not want to do. Now, that is a little complicated. I have made a checklist for myself and for you all that I will share that will be available to you. So I think that we can simplify this a little bit and be able to cover all of these things that the patient needs to demonstrate all of these things that the patient needs to demonstrate that they have capacity. Now, the simplified questions are these you can ask directly to the patient. Have you decided what you want to do? Have you decided what you want to do? That presses the patient to express a choice after you present those choices. Ask them what are the risks of the options we have discussed. So they can apply the facts. This is appreciation. They apply those facts that you present to their own life and they understand its relevance. So ask them what are the risks of the options we have discussed. The third question is, what could happen if you choose to do nothing at this time? What could happen if you choose to do nothing at this time? The fourth question is, why do you think this is the best option for you at this time? And the fifth question is, why have you chosen the option that you did? Now remember, this is not something that you're going to be able to remember all the time until you implement it in your daily practice and you use it routine, right? Because it's probably the first time you've heard of this for most people. When I researched this, it was the first time that I had learned about it. Now, if you have a patient that is borderline on your capacity assessment and you can't decide whether or not they meet capacity, I do recommend a more thorough, objective way to assess their mental status. And this can be performed by conducting a mini mental status examination, MMSE. Now, the MMSE was not created specifically for determining a patient's capacity to review. All right, so that is a disclaimer. It was not created for determining if they have capacity or not for refusals, but it is an objective mental status examination that you can use in conjunction with your other assessment with those 5 simplified questions that we went over to help you determine if this patient actually has the capacity to refuse. Now, if you're getting this far, you're probably at a point where the patient did not demonstrate obvious capacity. Okay, they're not wanting treatment. They're not wanting to go to the hospital. I get phone calls all the time from EMTs and paramedics where they're not sure if the patient demonstrates capacity. This is a wonderful tool where you can go through it fairly quickly. It is a little time consuming, but you're probably at the point to where you need to conduct this and you're going to have to call med control as a consult to get their opinion. Now, just remember though that patients are presumed to be capable of making choices for themselves unless you have reason to think otherwise. Capacity is essential not just for consent for transport, but also for medical care in general and treatment. There's not a single test, okay? This assessment tool will not demonstrate whether or not the patient has capacity. Not a single diagnosis, not a single test, not a single diagnosis. So a positive BAC, an elevated BAC, does not automatically mean the patient lacks capacity. Incapacity, so if a patient does not demonstrate capacity, it can be reversible. I get this question frequently, and you hear all the time that if you're on an overdose call and you administer Narcan, the patient responds to it and they wake up and they're alert oriented, you hear from law enforcement, you go with us or you go with them. Even a patient that has overdosed, that is now awake after naloxone, they can regain their capacity to refuse transport once they recover. It is no longer implied consent at that time. There are different types of capacity or competency. I may use those terms interchangeably because I get them confused sometimes. So patient needs to be legally competent. And I am not an attorney, but I believe competent is it is okay to say competent after legally competent. So legal competence is a patient needs to be, of course, of age, 18 years of age. There can't be like a court decree of incapacity saying that they're not legally competent to refuse care. And of course, we all talk about emancipated minors. Now, this is a sticky subject, right? What does that mean, emancipated minors? Well, we know that if a mother is under the age of 18 that they can refuse care, but does that mean that she can refuse care for her child and herself or just her child? Well, possibly not for herself, and it might just be that she can refuse only for the care of her child. In this situation, where it's kind of a gray area, maybe in some states, just call med control and get their input. They also need to be mentally competent. And of course, we have talked this whole time about mental competence, how to determine if a patient is mentally competent. You must always ensure that the patient is capable of understanding the risk of refusing care or transportation. Okay? Advise them of all the risk within your scope of knowledge. Advise them of the risk. Do not tell them the risk if you don't know if that is a risk. And it's okay to say that, hey, there is a risk of death if you don't go to the hospital. Now, it wouldn't be realistic to say that there's a risk of death if the patient stubbed their toe. So be realistic, be practical when telling the patient the risk of not going to the hospital. And again, the presence, when you're checking for mental competence, the presence of intoxication does not immediately mean the patient has a lack of capacity. Lastly, the patient needs to be medical or situational competence, needs to have medical or situational competence. So ensure that the patient is not suffering from a medical condition that could impair their ability to make an informed decision. This means ruling out shock, hypoxia, possible head trauma, hypothermia. If you believe that anything impairs the patient's decision-making ability, they might not be competent to refuse care. And in this situation, I again recommend you contact medical control. So how does the general refusal process work? Well, you fill out the form. You fill out the refusal form. Although that refusal form holds less water than a good narrative of documenting that the patient was advised of the risk, laying out what risk you advise of the patient, documenting your detailed assessment, not just physical, but of their capacity to refuse, contacting online medical control if you have a high-risk refusal or if you're not sure if the patient has the capacity, and of course making sure that the person who signs a refusal form is an authorized signer. And then at the end of it all, document that you informed the patient to call 911, their physician, or go to the ER if anything gets worse. So, in summary, we have to be careful not to unduly coerce a patient one way or the other. We need to avoid letting our biases surface when taking care of patients. Use checklist. Use your partner to perform a cross-check, and understand that you could be missing something, right? You are not a limitless pool or lake of knowledge, and nobody is. That's why we consult online medical control. And in cases that are high risk or when the capacity is not obvious, just have a low threshold to conduct an MMSE, call your supervisor, or call medical control. And as always, if you have any questions, feel free to let me know. Thanks, and bye for now.